So now we have the other possibility, the irregular narrow complex tachycardias. So we'll look at the options. The first one and the most common is atrial fibrillation. So chaotic atrial activity with no discernible P waves. In AF, it's considered that multiple waves or wavelets of depolarization are competing with one another to activate the atrium. Not all of them are conducted because the AV node gives us, fortunately, a physiological block. So not all of those depolarizations will reach the ventricles. Otherwise, we'd have a very high rate of even 300 beats per minute or more. When you treat AF, to slow down the rate, the most important thing is to treat the cause. And a lot of patients with atrial fibrillation with a rapid ventricular response will have the rapid ventricular response because of increased sympathetic activation. So say, for example, dehydration, pain, or a fever. Treating the cause is always the first line. Otherwise, you might employ pharmacological strategies like drugs that would slow down the AV node, things like beta blockers, calcium channel blockers, and digoxin. The rare thing to watch out for with AF is when the rates are extremely fast. I'm saying 200 beats per minute and above. And this is because this might be due to a bypass tract or an accessory pathway that connects the atria and the ventricles. The heart rate can even go to 220, 360 beats per minute. Typically, you would get a wide complex rhythm because there is cell-to-cell conduction. And there is normally beat-to-beat variation in the QRS morphology. However, if you used AV nodal blockers like a beta blocker or a calcium channel blocker in this rhythm, it could be fatal. You could actually worsen the conduction through the accessory pathway and you could trigger a ventricular arrhythmia. So in reality, if the patient was unstable, you'd shock them in this case. And instead of slowing the rate down with a beta blocker, you might employ a different antiarrhythmic like procainamide or ibutilide. So next we have atrial flutter with variable conduction. And in this example, you can see that the flutter waves are superimposed onto the T waves. And this is a common reason to miss the flutter, as we discussed in the last video. So in flutter, you can have variable conduction leading to an irregular rhythm. Sometimes you can have a slow conduction as much as 5-1, 7-1. And this can give you an idea of the function of the AV node. Maybe a patient is on a beta blocker, or maybe there is some underlying AV nodal disease. Unless the patient's symptomatic with syncope, chest pain, shortness of breath, this kind of slow variable conduction is not really concerning by itself. So finally, we have MAT, multifocal atrial tachycardia. This is when there's multiple sites, at least 3 different sites in the atria attempting to act as the pacemaker with increased automaticity. Each of the sites has a different internal rhythm, and therefore the rhythm will be irregular. You'll often find multifocal atrial tachycardia together with pulmonary disease like COPD, asthma, chest infections, and so on. And what's important is you don't shock patients who have MAT. You treat the underlying cause. And generally, it will resolve. So on the ECG, we'll see 3 or more different morphologies of P wave and a rhythm of over 100, but typically less than 150 beats per minute. So 3 different morphologies of P wave and also variable PR intervals.